Hi, I'm Joe Elsissy. I'm an orthopedic trauma surgeon with Arrowhead Orthopedics. I serve as the orthopedic trauma director at Arrowhead Regional Medical Center. Arrowhead Regional Medical Center is a level one county trauma hospital for San Bernardino in California. Um, I also serve as the clerkship director for the Loma Linda Orthopedic Residence County Trauma Rotation. Uh, and I serve in a number of administrative and educational capacities within the residency. I love teaching medical students and residents, and I think this educational opportunity that's being presented today will provide a wonderful bridge to a gap that's existed for a long time regarding placement of skeletal traction pins. I think for a long time, and probably still today, the way that people learn how to place skeletal traction is by the see one, do one, teach one method. And I think this educational resource will be very valuable at all levels, whether you're a junior resident getting ready to do this for the first time, or a senior resident wanting to refresh yourself, or at the level of the residency program, where I could see this being a resource that gets presented during the introduction part of the residency, like a boot camp week or something like that, so everyone can get a primer and an educational experience before they get ready to start doing these procedures. Soon, Dr. Allen Nedley will go through a really nice presentation that he prepared regarding the technical details of skeletal traction. I've known Allen for a long time, since the time he was a student, and he and I were briefly residents together, and he also was one of my residents when I became a faculty, and I'm really proud to call him a colleague in orthopedic trauma now. He works at a level one trauma hospital in Flagstaff, Arizona, and he's an outstanding trauma surgeon and an even better guy. Before Allen Nedley gets ready to present the specifics on placing the traction pin, Dr. Vemulapalli will go through the indications and decision making when deciding which patients require skeletal traction. I hope you enjoy the lecture and the material that gets presented, and thank you so much.
Hello, everyone. I'm Chandra Vemulapalli. I'm one of the orthopedic trauma surgeons at Tulane, and I serve as the chief of orthopedic trauma for our service at University Medical Center, and I'm also the associate program director for our orthopedic residency. We're all very excited to bring you this surgical technique lecture for bedside skeletal traction. Our goal audience here is junior residents, because I certainly remember when I was a junior resident, when I trained at UT Houston, and this is one of the first procedures that you get to do with your power tools that you get excited about. You're treating these patients on your first nights of call, and these are certainly things that I look forward to doing when I was a junior resident, seeing all my consults. And so we collaborated with surgeons across the country to ensure that this resource is valuable nationwide, and we'll be using it here every year, and we've been doing this here for a couple of years at my home institution. So we hope that this will be valuable for all of you moving forward. First, we'll be covering when to use skeletal traction. Then Dr. Allen Nedley will be going through the entire workflow from landmarking to applying skeletal traction and sharing some of the pearls that he's learned throughout his time as a resident, and also that we've shared with him from our times as residents when forming this procedure to make it as smooth as possible for you. Some of the most common indications of skeletal traction are shortened femur fractures, unstable acetabular fractures, and vertically unstable pelvic ring disruptions. For shortened femur fractures, our goal is to restore length by putting axial traction on the longitudinal axis of the limb. Once the length is restored, the muscles are closer to their anatomic length, decreasing spasm, increasing pain control, and restoring muscle length to also increase their tension, which can tamponade the bleeding at the fracture site, decreasing blood loss. For unstable acetabular fracture dislocations, traction is used to maintain the reduction of the femoral head and the acetabulum. It can also decrease pressure on the femoral head on the fracture fragments and offloading the injured cartilaginous surfaces, and also potentially decreasing the displacement prior to surgical fixation. In some cases, traction can also be used to alleviate pressure if there is intra-articular debris, or to keep the femoral head from traumatically medializing into the true pelvis with largely displaced acetabular fractures or with medializing patterns. Skeletal traction also not only helps relieve pain and reduce muscle spasms with vertical shear type pelvic ring disruptions, but can also decrease blood loss and also increase the tamponade effect when achieving hemostatic control. In some cases, traction may be necessary to maintain the alignment of these vertically unstable rings to mitigate further displacement in the interim period from when they present to you in the emergency room and when they're able to go to the operating room for surgical stabilization. Before you begin the procedure, you'll need to determine your pin placement, ensure that you have all of the appropriate imaging of the fracture and the bone that you plan to place the traction pin through. Please do not place a traction pin without having adequate x-rays of the area you plan to place this pin in. The last thing you'd like to do is find out that you place this through an injured area that then may require further intervention to correct. You may wish to consult with your team so you can determine the best course of action from the get-go and gauge your upper level residents as well as your attendings to ensure that you're following the institutional guidelines for how these fractures are treated with the appropriate type of skeletal traction. In general, distal femoral traction is usually preferred so you can avoid pulling through the knee musculature, which often can be difficult to assess in a polytraumatized patient with fractures particularly of the femoral shaft. This can also ensure better control of the hip joint during traction as you're pulling through less joints and is more mechanically effective. Femoral traction, however, can be difficult in some of these morbidly obese patients if your pin is not long enough. And also there may be some injuries where you do not want to place a pin in the distal femoral region because of how close the fracture is or what other mitigating factors. And so proximal tibial traction is also an option. When determining your entry site, you'll also want to take into consideration any being nearby to any planned operative incisions, any skin lesions or open wounds such as road rash or burns. And it's also important to note that this is what is done at my institution. Institutional variability certainly exists for when to use femoral versus tibial traction. So consult with your team to uncover what your facility prefers. So without further ado, I'd like to now introduce Dr. Allen Nedley to take you through the workflow and the procedure.
Thank you, Dr. Vemulapalli and Dr. Elsissy for your introductions. My name is Dr. Allen Nedley. I am an orthopedic trauma surgeon in Flagstaff, Arizona. I work at Flagstaff Medical Center, a level 1 trauma center here in northern Arizona. We are the only level 1 trauma center in Coconino County, serving the entire northern region of Arizona, as well as some of New Mexico and southern Colorado. I was in your shoes not too long ago as a junior resident, and I've placed a lot of pins myself over the years. And I found at that time that I was placing these pins for the first time, there was no real educational resources available for how to place these pins appropriately. So that's part of what brought me here today and brought Dr. Elsissy and Dr. Vemulapalli here, is we wanted to help you master this procedure, and this resource we hope can be a good tool as you learn this procedure. So let's dive into actually how to perform this procedure, and we'll discuss each step in detail. There are 10 steps for performing skeletal traction, and these are the same for femoral and tibial with a slightly different variation in regards to landmark and patient positioning. We're going to go over each of these steps and discuss everything that's involved. The first step is gathering all the materials that you're going to need to perform this procedure. At our hospital, we have a kit that has everything that we need in it, but you may need to gather these individually. So you may need to gather your pin driver, your bow, your wire kit from the operating room or sterile cord, and your traction kit and frame from the bed. It's very helpful to involve ED staff or a tech or someone else to help you gather these supplies, as it can be pretty time intensive. Another tip is to ask for your lidocaine early or put the order in early for that, as sometimes it takes a bit of time to get the lidocaine from pharmacy. And of course, ask for help if needed, if this is your first procedure, to know what you use at your institution. And make sure you get your weights as well, as sometimes these come from the operating room. Once you have all your equipment, you can then turn to positioning the patient appropriately. You want to make sure that the patient's leg is bumped, so that way when you're placing your femoral traction from the medial side, you don't bump into the contralateral leg. And for the tibia, it's kind of the opposite. You don't want your pin to hit the other leg after you place it, so bumping the leg that you're working on is helpful. So regardless for femur or tibial traction, you want to make sure that the leg is bumped so you can clear the contralateral side. Once the leg is appropriately bumped, you then want to derotate the leg, and the patella should point towards the ceiling. Sometimes it's helpful to also bump the leg to keep it derotated as well during this procedure, but definitely ask for help or an extra set of hands as you do this to help hold the leg. Blankets, pillows, towels, whatever you have available, generally all of those work pretty good for bumping the leg. Now that your patient has been positioned appropriately, we want to talk about the key landmarks. Identifying key landmarks ensures appropriate pin placement. For the femur, the pin is driven from the medial side to the lateral side. And for the tibia, it's driven from the lateral to the medial side. So by starting the pin at the structures at risk, you can guarantee that you're going to avoid those and you'll have a safe placement of the pin. For femoral traction, you want to mark the patella, you want to mark the joint line, and then find about 2 centimeters proximal to this. Then you want to find the medial epicondyle, and again, look for a spot 2 centimeters proximal to this. This ensures that you're going to be out of the joint capsule, but below the structures at risk. On the medial side, you have the saphenous nerve, and then behind you have the femoral artery. And so by ensuring that you're staying anterior to this and proximal from the joint capsule, and then distal from the nerve, you're going to be in the appropriate starting position. For tibial traction, mark the joint line again, mark your patella, and then mark your tibial tuberosity, and then find a spot 2 centimeters distal to this and 2 centimeters posterior. It may need to be a slight variation in these distances based on the patient's size, but generally this is a pretty good landmark. Your structures at risk are on the lateral side, and that's your perineal nerve, along with your anterior tibial artery. Identifying these landmarks again is key to ensuring that you're going to avoid them, and you'll have appropriate starting position for your wire and for your lidocaine placement. Once you have your appropriate starting position identified, you want to then inject your lidocaine. I inject about 20 cc's of lidocaine, about 10 on the entry site, and about 10 on the exit site. You want to create a nice wheel and then take your needle all the way down to the periosteum and make sure you have some lidocaine down at the periosteum. It's also helpful to find the bone with your needle, as this gives you a kind of an early landmark or an early guide about where your pin's going to be placed and if you're too anterior or too posterior. On large patients, especially on the femur, you may need to get a spinal needle to reach the periosteum, and they do make smaller spinal needles like a 22 gauge that's helpful, that's not quite as large as an 18 gauge. Once you have your lidocaine placed, you can then work on other things for 1 to 2 minutes, getting your kit all set up to give it some time for the lidocaine to set. So before we drive the pin across the bone, we want to make sure that we locate the appropriate position of the pin. That may be the center or the anterior third, depending on the institution, but locating the center is very important. You want to begin by inserting the pin at your location where you made that lidocaine wheel, and then you want to push the pin to the bone, and then you want to march it anterior and posterior to find the anterior and posterior cortical limits of the bone. You may need to repeat this and move the pin posterior a little bit if you're finding that you're too anterior or too posterior. Ensure that you don't push your pin too posterior, especially on the femur and the tibia as you're doing this, because your structures at risk are behind the leg, and so by advancing the pin significantly in the posterior area, you may be very close to those structures at risk. And as we mentioned, it may be, depending on your institution, it may be something where you're going to put your pin more anterior instead of more center. It just depends on the institutional variability. For the tibia, this is the same step. However, there is a slope to the proximal tibial metaphyseal region where that pin's going to be placed. And so just be mindful of this, as the pin tends to try to slide anteriorly from that lateral face of the tibia. So now that we found the appropriate position for the wire, we're going to talk about driving the pin across. Remember, for femoral traction, we're going to be going from medial to the lateral side to avoid those key structures. So once you have your pin in place, you can connect it to your wire driver or to your other driver is in this Arbutus kit. Ensure that the leg is held derotated as you're going to drive this wire across. And then you want to hold the pin guide about 2 to 3 centimeters from the skin and brace your knuckles on the leg to control for pin deflection. You want to drill with speed, so pull the trigger all the way down, give it some pressure forward. This helps you feel both cortices and also prevents the temperature from increasing too much on that pin as you're driving it through. Again, don't worry about the pin bending between the guide that you're holding and the drill. That's normal. Just keep the pin straight between the guide that you're holding and the patient's leg. You should feel the pin go through both cortices, and then you can ensure that the pin is bicortical by toggling the side. You may do this before or after trimming, but ensure that the pin is bicortical. Then it's helpful to place those pin caps, those are really nice pin caps. So keep those around and put them on the wire to keep the wire from poking you or the leg or something like that. Let's talk about the tibial side. You want to drive the pin from the lateral to the medial side on the tibia. And due to the slope of the tibial face there on the lateral side, the pin's going to try to skive anteriorly. So it's helpful after you connect your pin to begin perpendicular to the tibia. So this is going to be aiming slightly toward the floor. You can start the pin, and then once you have the pin started, it's going to create a bit of a burr. You can drop your hand and be parallel to the floor, ensuring, again, that the leg is derotated as you drive this wire. Again, pull the trigger fully, advance. You should feel 2 cortices as you advance here across the tibia. Again, you want to double check that the pin is bicortically placed, and you want to do this by toggling one side, and you shouldn't notice any movement on the other side of the pin if it's placed bicortically. You can then trim the ends of the pin and put your pin caps on to ensure that it doesn't poke the contralateral leg or you or a nursing staff. That's very important to have the pin ends protected after you place this wire. Now that you place the wire, you can ensure that it's appropriately placed with X-ray and then apply your bow. So tension bows are required for fine wire tractions, and this is to prevent the pin from bending. And a bending pin is not desired because that can cause pressure on the skin, which can cause skin breakdown. So once you've ensured that the pin is appropriately placed, you can then secure the pin to the bow. You want to ensure that there's enough space, I like about 1 to 2 centimeters between the skin and the bow. This allows you to place dressings between the pin and the bow. On large patients, you may have to actually open the bow before you put it over the leg to get it to get it open enough, I should say. Then tighten the bow, and more tension is desired over less tension. That prevents the bow from falling off, first of all, but also prevents your pin from deflecting, which can prevent some of that skin breakdown. Once the bow has been applied, you can then apply your pin care. I like to do Xeroform and gauze, although there may be some institutional preferences on the desired dressings here. But something just to kind of bolster the skin, to keep the skin from moving. You may also notice that there's some oozing here at the site, so just reinforcing this as needed is a good idea around these pin sites. After your dressings are applied, your bow is applied, we are now ready to talk about applying the traction weights. On the left here, you'll see a picture of the weight being hung directly off the bow. So depending on your facility, you may be able to hang the weight directly off the end of the bed and attached to the bow, or you may use a traditional traction frame seen in picture B on the right side of the screen. The amount of weight to hang is starting is about 10% of the patient's body weight, so usually anywhere from 10 to 25 pounds of weight. Once you have your weight set, you want to apply it gradually. So fill your water bag or get the weights, get the amount that you need, and then apply it gradually to the patient's leg. This makes it a little bit more comfortable. And then you want to ensure after you've applied your weight that the patient's leg is not touching the bed. So if the patient's leg is short and you apply the traction, it may pull the leg to length, and you may notice it's now touching the footbed. So you want to move the patient up so that their foot is not touching the end of the bed, otherwise the traction isn't going to work. So this is all the steps we've talked about as how to apply the traction. Let's go over a few steps just how to verify and kind of check up on your traction after you've placed it. Immediately, we talked about toggling the pin to ensure that it's in the bone. You can also get the lateral X-ray to confirm that the pin is in the appropriate position. So again, institutional variability here, some on the anterior third, maybe in the center, and you may want to do this before your traction bow has been placed, as the bow may prevent you from actually seeing where the pin is placed. So I like to get my X-rays with just the wire and no bow on it. And then you want to get appropriate imaging to ensure that the fracture has been reduced, or that the reduction of the joint or whatever it is that you're trying to maintain is working correctly. So then you can adjust your weights accordingly. Some fractures, you may not need X-rays every time, but if you are looking at a reduction or something, especially of a joint, you may get those X-rays and verify that the traction is appropriately placed and you have the correct weight. When rounding, it's also helpful to keep checking on your tractions. You want to make sure that the weight is hanging and not obstructed so that the weight is not on the floor. You want to make sure that the patient's foot is, again, not touching the footboard, that they haven't slid down the bed. And that's pretty common, especially as they sit up. They might slide down, so you may have to slide the patient back up in the bed. You want to ensure that the leg is derotated appropriately, that your tension bow is tightened, the pin is not sagging. You want to make sure that the tension bow is not resting on the patient's tibia. So if you're hanging the weight directly off the bow, as you saw in that one photo, this kind of keeps the bow elevated. But other setups with a more traditional frame, you may have to elevate the frame to make sure that that bow is not touching the tibia, because you definitely don't want skin breakdown underneath that bow at the tibial tubercle or on the anterior side of the tibia if it's a tibial pin. And then make sure that your pin caps are still applied and that the pin is not poking the other leg or poking into the bed. Let's go over a few things that I found that are important and a couple pearls as you're placing traction. Talking to the patient is probably one of the most important things you can do. They're definitely going to be a bit anxious if they're awake, and so letting them know what you're going to do will help with their anxiety and can help with the pain. You want to ask the family to leave the room. You know, it's pretty traumatizing to watch someone put a pin through the leg if they haven't seen that before, and so it can increase anxiety for the patient and family if they're in the room, and you don't want a family member passing out as you're doing it, so it's helpful to have them leave the room. Again, knowing your steps so you're confident, so you're smooth, and you're efficient throughout the procedure is very important. Again, slowly applying the weight so that you're not, dropping the weight on the leg will reduce some of the pain as you're applying that. Letting the ER staff know you're doing the procedure and keeping them involved is really important. You may want additional pain meds on board, so having the ER staff order some of those or get some of those for you as you're doing the procedure can definitely help. And again, asking for help from the staff around to hold the leg or to get supplies or whatever you need. Make sure you include other people if you need help. And then lastly, understand that these procedures vary by institution. So make sure that you include your senior residents or your attending as needed to ensure that you're performing the correct procedure at the correct site and you're doing the right thing for the patient. There's additional resources for continued learning that I think you may find helpful. For residents, there's a website here, the Arbutus page, where there's a resident learning page, and you can find some guides to go through. They also offer a free online course there that you can kind of go through how to perform skeletal traction. And there's also a Arbutus medical YouTube channel where there's a skeletal traction education playlist where there's step-by-step education animations, procedure videos, other lectures and webinars and things to come. So definitely feel free to check that out as you're learning about this procedure. Lastly, I want to talk about the TrakPak demonstration. So as I mentioned here at the beginning of the talk, at my facility, we use a kit that includes everything that we need. So it's standardized. And this kit's called the TrakPak kit. It includes all of our disposables, the bow, the wire, a sterile drill cover. The only thing it doesn't have is lidocaine and gloves, and that's pretty easy to get. So just get those ahead of time, and then you can get the kit and you'll have everything else that you need. It definitely reduces time gathering all these supplies by having it in the one kit. And it definitely decreases the amount of time until you can get the traction applied. So it definitely helps with patient outcomes by having that traction on sooner. Included with this TrakPak system is an FDA-approved power system that will quickly connect to that pin, and it doesn't have to get reprocessed. So there's a sterile cover that goes over top of the drill, and so after the procedure, you can just wipe it down and use it again for the next procedure, and you don't have to get that from the sterile core or the OR. There's also a wire cutter that's included to be able to trim the wires after the procedure. So to prepare for the TrakPak kit, you're going to first want to open the procedure kit on a side table. So you can see here there's a lot of things included. You want to have a sterile table where you open that blue wrapper and then a non-sterile surface to be able to place the drill on its back. So there's a box that includes the sterile pin and the drill cover, and so keep those on the sterile side, and then you want to move your drill to the non-sterile side and be ready to be able to place that sterile drill cover over it. So first you want to place your sterile gloves on, and then you can open the peel pack pin and drill cover and place those on your work surface. You want to unfold your sterile cover, and then you're going to pick up that cover, put it over top of the drill, and then you can pick up your drill through that cover. So if you see here, you move your hands to the front, you can grab the drill, then you can unfold it, remove the adhesive cover and seal the drill off. Once you've covered the drill with the sterile cover, you can then move it onto your sterile work surface and ensure that you keep those pin caps that are on that wire. So you notice there's a pin cap on the end of the wire, the 2mm wire that's included. You want to remove that before the procedure, of course, and then there's another one in the bag right there, kind of highlighted on that wrapper. So don't throw that wrapper away. Get those pin caps out before you throw them away. And so you're now ready to kind of do the procedure. Before I set this up, I always have my lidocaine in, so that way I can already be waiting for that to set up. So once you're confident, we've found we've made the lidocaine, we're confident with the pin position, we can drive the pin. You want to hold the pin guide and slide it 2 to 3 centimeters from the patient's skin, and you can brace your knuckles on the patient's leg to keep the pin steady and level. You want to ensure that the pin is level to the floor while keeping that leg derotated as you do the procedure. Again, pin bending on the side of the drill is normal, but keep the pin straight on the side between the guide and the patient's leg. And then once the pin is through the bone, you want to make sure that the pin has been placed bicortically by toggling the side closest to you to ensure that there's no movement on the other side. And then you can remove the pin guide, you can trim your pin ends, and then you can put the pin caps on. And these pin caps that are included in the kit, I can't really stress enough how important it is to keep those. They're way better than everything else in the hospital for putting for a cap. So there's one that in the wrapper, don't lose that as you put it on. The weight then, applying your weight is really easy with the quick bow. So there's a spring-loaded cam that bites nicely onto the wire. You can then hand tighten that the blue handle, and again, you want to apply as much tension as you can apply with hand tightening to ensure that the pin doesn't deflect and that there's not that the bow stays secured. And then you want to connect those adapters, the carabiners, to the bottom of the bow there, and then apply your weight. And again, ensure that the weight is not touching the floor, and you may need to elevate the patient's the weight bag to keep it off the floor. You notice as the weight is applied in this video here that the bow elevates off the tibia. So that's a really easy way to ensure that the weight is being applied by looking at that bow, ensuring that it's elevated off the end of the bed. Right here's another kind of demonstration. As the weight's applied, the bow is elevated off the tibia so that you know that the weight is still applied. So that's how easy it is to apply skeletal traction. I mean, it's a pretty simple procedure. And again, with following these steps, you're going to have great success as you do this. I want to thank you all for listening, and I want to thank those that helped put this presentation together. It wasn't too long ago that I was in your shoes, and this resource would have been a very helpful resource in learning this. So we wish you all great success as you're doing this. Refer back to this video as needed during your rotations. Refer to share it with friends, and we hope you learn this and you succeed as you learn this foundational skill. Thanks again.